Hi, this is Dr. Christy DeSavry, founding physician of Bone and Body Women's Health. I got a question about treating hot flashes or vasomotor symptoms or night sweats in women who have breast cancer or who were recently diagnosed with breast cancer. I think this is a really important topic because oftentimes when women are undergoing these cancer treatments, having these diagnoses, it often correlates with the time of menopause. Women are between 40 and 60, having symptoms of vasomotor symptoms, hot flashes, sleep disturbance, and on top of that, they are undergoing cancer treatments, possibly surgeries, radiation, and just all the emotional and physical stress that go along with that. So I think the most exciting thing in the last couple of years is that we have realized that there are non-hormonal treatment options for vasomotor symptoms and hot flashes. We're actually really good at treating these symptoms now. And in the last year, we've had a very exciting new medication, new novel class of medication, which is called phasolinetin, which inhibits the hypothalamus, and it works on the neurokinin receptor B neurons in the brain, and it really affects how hot flashes are sensed and how our body really does not sense those hot flashes and does not trigger an active hot flash, and decreases the risk of hot flashes as well as severity and frequency. We have other non-hormonal treatment options. We have for many years studied SSRIs, or serotonin selective reuptake inhibitors, or SNRIs. We have some of those off-label uses as well. There's one that is FDA approved called paroxetine, 7.5 milligrams, and we have other medicines in that class that we also use. A medication called gabapentin is another option. This is mostly used for things like migraine or things like nerve or muscle conditions, but we know that at nighttime dosing, this can help women with hot flashes. We had another medication that was now really recognized from the Menopause Society as having some good data behind it, and that's a medication called oxybutynin, which we use for overactive bladder or urge incontinence. However, we know that we can dose this medication 2 to 3 times a day and use low doses, and it also affects and reduces the risk of hot flashes, and again is a non-hormonal option. What we know with pretty good reason is that there's many botanicals and many herbal supplements, etc., that unfortunately have a very strong placebo effect. So when our patients take them, they feel good for a couple weeks or maybe even months, and then that effect sort of wears off. So unfortunately, our world's data of looking at botanicals like black cohosh or, feverfew or all these other products, we really have not held up when we look at rigorous scientific data. And what I say to my patients, if you want to try those, sure, but if you really want to get rid of your hot flashes and menopausal symptoms, if you're not going to take hormones, or we can't take hormones for various reasons, then let's go for an FDA-approved non-hormonal option, which really now we have multiple options that you've just heard here to really treat. So ranging from SSRIs, gabapentin, oxybutynin, or phasolinetin. So I think we're going to see more in this class, and these primarily are helping with sleep disturbance, hot flashes, as well as night sweats. And I think that it's really great that we have options for patients who are undergoing breast cancer treatments, cannot take hormonal options, and might be also survivors still struggling with vasomotor symptoms. As we know, hot flashes can continue and are not just associated with the time at menopause. 20% of women can have hot flashes lifelong, and certain ethnicities, medical conditions can portend longer hot flash histories. So important to treat your hot flashes any way you can. Hope to see you soon.